right. Well, good afternoon, everyone. Today I'm going to talk a little bit about depression and psychosis, and more specifically, really depression within the context of schizophrenia. Um, Partly because it's sometimes a bit overlooked, only in the sense that sometimes the positive symptoms, hallucinations, delusions, disorganized thinking, or behavior kind of overshadow a bit at times. And so sometimes the depression may get lost a bit in there, or if the individual presents with negative symptoms, which can look a lot like depression, it may be assumed because there's a schizophrenia diagnosis that may be more kind of in tune with negative symptoms. So really just kind of trying to take a little different lens and looking at different pathways for recovery within that. And within the psychosis, we're going to spend some time on how a person's relationship with hallucinations or voice hearing experiences kind of ties in here. So it's a little bit focused in that way. Hopefully, a bit enough general stuff that folks will be interested in. So I'm going to talk just a little bit about negative symptoms and depression, how to differentiate. Um, a little conversation around some common pathways where depression shows up in schizophrenia, and then just a little bit about targets to focus on when there are depressive symptoms within the context of psychosis. So, what are negative symptoms? Most folks, I believe, on this call or on this echo are familiar with negative symptoms. It really is this presentation where there's a real diminishment. There's kind of an absence of a lot of things, and sometimes it's referred to rather not thinking about negative as something bad, but as something taken away from the individual. So the way the individual may appear is very flat emotionally, not engaging in activities, may neglect hygiene, a lot of social withdrawal. There's limited speech. Sometimes we call that poverty of speech, lack of motivation, all these things, which can look a lot like depression, right? I mean, these can kind of look a lot like that. So how do we differentiate? So just on the left is just a list of common symptoms of depression, and on the right, common symptoms of negative symptoms. And you can see that there's definitely some overlap. I've highlighted in yellow the symptom clusters, which tend to help us identify depression. And so remembering to kind of really check in on the depressed mood, check in on the thinking, worthlessness, guilt, pessimism. A lot of those thoughts go in with Aaron Beck's cognitive triad of depression, really negative thoughts about self, about others, the future, about things around the person are really tied into the depressive symptoms. And of course, thoughts of death or suicide tied more closely to depression. And on the negative symptom side, flat or blunted affect, which I've mentioned, but also the slowing or poverty of speech. One of the interesting little notes that I saw when I was reading over this from one of the CBT texts was that they looked at individuals who were released from the hospital who had poverty of speech as one of their symptoms while they were hospitalized. And then post-treatment, those with depression, the poverty of speech went away. They talked a lot more, were more engaged. Those with schizophrenia tended to have an increase in poverty of speech following treatment afterwards, which was kind of interesting. And I'm not sure what to make of that exactly. It could be somewhat medication related, could be isolation following that. I'm not quite sure, but just a little interesting tidbit. When we look at depression and schizophrenia, like how common it is and why it's important, it is fairly common, occurring kind of within 40% of individuals with schizophrenia, and then kind of looking at it over time, up to 80% in the early phase will report depressive symptoms. So we need to pay attention to it. It's important because it's one of the most significant factors predicting completed suicide, even more so than command hallucinations, which sometimes gets a fair amount of attention in terms of people following commands to end their life. Depression is also linked with transition to clinical high risk to first episode psychosis. So some important areas where we want to pay attention to it occurring. Now, thinking about how depression shows up within psychosis with schizophrenia, Birchwood and then followed by Up the Grove did a nice kind of a deeper dive into this. And they proposed three pathways, if you will, to get there. One is that depression is just simply a core dimension of psychosis. It's just one of the things that kind of goes along that pathway. A second pathway is that depression can be seen as a psychological reaction to the psychotic experience. And I'll talk a bit more about when a person hears voices, their relationship with the voices kind of puts them in a subordinate kind of role and how that links with depression. The other reactant sort of pathway is kind of just the social status and the marginalization that happens when somebody receives the label of schizophrenia and then how that stigma can be internalized, and that internalized stigma can kind of feed depression as part of that. And then they also point out depression as evidence of childhood trauma, indicating that when there's a history of trauma, 2 to 15 times higher in depression with psychosis than non-psychotic depression. I should also say that individuals with schizophrenia also have just a high likelihood of experiencing some sort of traumatic event. So again, this can get a little bit, I guess, sort of fused together with the idea that, kind of trauma happens early on, and that feeds maybe the depression and psychosis process in parallel. So let's talk just a little bit about the reaction approach or the reaction pathway. So the experience of voice hearing for many is associated with the feeling of entrapment, right? So voices happen. Why is this happening? Where is this coming from? And people can experience voices being very powerful and omnipotent. And when that happens, and it happens repeatedly, they can feel like they're in an inferior position related to the voices. And so they have a social rank theory that they refer to, Birchwood and their colleagues. And that is when a person is in a kind of an inferior position that way, there are certain factors that go with it, such as a person feeling like they don't have power, maybe responding more passively or submissively in those kind of contexts, and also just being on high alert for threats continuously. And there can be feelings of shame and humiliation kind of connected to that. So that in itself can contribute to depression. And then there's a separate kind of line of thinking that the relationship the person has with their voices, how they respond to the voices, particularly if they feel subordinate to the voices, can parallel current other relationships in their life. So then that also kind of helps us think about like what else is going on in their social world, and how do we help them kind of in their environment, not only with the symptom, but like what else is going on in their life to pay attention to. Um, and so the end result of these things going on is the kind of marginalization, loss of sense of self, depression, can be all connected with that. Now, in CBT, we like to put things into formulation. So how do patterns go together? And so at the top of my little pattern here is the person who hears a voice that may say something like, "You're nothing, you should hurt yourself." And the reaction to that may be something along the lines of, "I have to do what the voices say, I have no power, I'll have no life and not amount to anything." So there's all these connected associations to it, which then, of course, you can see how that links to fear and depression, which then can feed isolation. Some of this passive behavior, maybe appeasing the voices. And then there's following that decreased engagement, depression, inactivity. And so you can see how that spiral develops. Now, if you go to the right part of my column here, this is sort of the larger context. So this may be an individual who has early life experiences of being bullied, where abuse may have happened. And so current life events activate that schema in the language that we use. And so that's one contributing factor. And then there could be societal influences in terms of how the person is treated. Specifically thinking about internalized stigma, and family often can be supportive, but they may be in a situation where family is critical given the situations. And then the core beliefs connected to that is I am vulnerable and weak. And all of that kind of feeds this depressive loop that can occur. So that's one pathway where it's kind of a reaction to the symptom itself, if you will. The other pathway has to do with this internalized stigma that I've mentioned. And there's something that is in the literature referred to the insight paradox. You may have heard about this. The basic idea here is that when individuals who have schizophrenia who have higher insight, this is often associated with better treatment adherence. Makes sense, right? I have schizophrenia, I have this awareness, treatment is necessary. But there's also this other correlate that it's associated with depression, low self-esteem, and lower quality of life. Now, this data is a little bit older, but this is where the paradox comes from. And then, of course, we know with lower insight in schizophrenia, there's treatment non-adherence, and then there's other consequences that go with it. But the insight paradox is more insight equals better engagement, but more depression. When they looked at this closer, it appears to be moderated by this internal stigma. And the way to address that, or another way to look at it, is hope. All right. So there's this connection inside hope and quality of life. So when they measured hope along with some of the other factors like internalized stigma and insight, they found that the presence of hope mediated this negative relationship. So that when a person had insight, but they had hope, and they can kind of view their life with hope and optimism, the internalized stigma didn't follow that pathway to depression as often. And so the authors Hassan Olyan write about increasing hope is a very important thing. And part of it is not only that life can be better, but also allowing the person to differentiate their identity from the mental illness and maintain hope in the face of stress. So a lot of factors pointing towards a lot of work that we do is helping people to develop that sense of hope and optimism in their life. So, and again, this is going to be rather simplistic and just in these couple of areas, but like, how do we target treatment based on some of this information? And hopefully, our treatments in general, contain a lot of these elements that I'm going to talk about, but then we can also specifically focus on things. So, just to create this contrast, with psychosis and depression, fear, loss of control, powerlessness, and they may be thought of as dangerous. And so that's the stigma piece. The recovery path that we try to work with or develop involves how do we help develop a sense of safety? Where can we look for opportunities for empowerment? Doing purposeful things, being active, having autonomy, but also a sense of belonging, connection to the community. Um, Specifically intervening in the factors that I've just mentioned, related to voice, content, and kind of command quality and how a person relates to them, we really focus on helping them better understand how they can gain some level of control and better understanding of voices in their life, as well as relating to the voices perhaps differently. We're going to pay attention to family and other supports and how to strengthen that relationship to kind of make those patterns positive and supportive. And then also look at and help them look at the different events that occurred within their life and take a look at how stigma may have been activated there and how to work with it. So these are just some general strategies within CBT that we will often employ, and I can certainly talk about this more in a question and answer if we want to dig deeper into any particular area. One of the big categories for depression and negative symptoms is something called activity scheduling. And this really starts with understanding what's meaningful to the person, what they have as aspirations in their life, and helping them to plan more of those activities and finding even the smallest ways to integrate these activities in their life to build a positive sense of self, empowerment, and hope. And it's not only planning it and helping them activate some of these activities. The other piece that's important is the active review of it, like really asking, like, what does it say that you were able to do this art show, go to school, do this volunteer, have a cup of coffee with your friend, helping them to actively integrate those activities into this sense of self as a person activating their values, living according to those, and taking steps in their life is a really important part of that. In CBT, as you guys know, cognitive behavioral therapy, we do a lot of cognitive restructuring. So evaluating and reframing how a person thinks about the voice hearing experience. And even the simplest ways to work with them if they feel like they have no control in relation to the voice and they're distressing all the time. If you work with them around strategies to kind of help lower that sense of distress, feeling like the voice isn't in control all of the time, you've empowered them, or there's a sense of empowerment that goes with that. So a lot of our strategies are targeted that way. In CBT, we use a lot of normalization examples. So we share a lot of stories of individuals who experience psychosis, depression, lots of things, and who do things in their life. They're able to be advocates, they work, kind of really showing that having a diagnosis does not limit them completely, that they can still achieve and pursue activities in their life. So we do a lot of that work. Related to the relationship with the voice, I've already mentioned a little bit around the cognitive restructuring, help them kind of test out maybe some beliefs that they have about the inability to do things because of the voices. An individual I worked with really wanted to do artwork, but stayed away from kind of art shows and doing it because the voices kind of prevented that. And we slowly worked towards being able to submit works of art and participating in art shows as a way to challenge that belief and see that they could do things. And also to kind of help the person reframe the relationship to the voice. Often individuals will have a very antagonistic and angry sort of arguing relationship with the voice, and that can sometimes be altered, which then can lower some of that threat vigilance things that are going on and just kind of create a different environment for interacting. So that's another area that we work in. And then just in general, cultivating the ability to pursue quality of life, even while hearing voices. So it's not the strategy of like, let's wait till we've got these voices under control to try things. Let's help you to re-engage in your life, even if these are happening. And then often what happens is that by engaging in meaningful life events, the distress and the frequency of voices often will decrease. We try to be very systems focused. So, what are the things or who are the individuals important in an individual's life? And it can be biological family, but it can also be others, supporters, other people important in their life. Doesn't have to be biological family. But looking at things like, is there criticism? Is there over involvement? Some of those kinds of factors. A lot of reasons for that. Sometimes overall stress and arousal at home, negative interactions can strengthen negative beliefs about self. So it's really just encouraging providers to bring family or others in their life, to the extent that the person will allow and want them to kind of bring them in to kind of talk with them about how can we intervene, how can we do things differently. Sometimes it's education, helping family have a better sense of psychosis and what this means and what's possible. Sometimes it's just helping with different patterns of interaction. I recall working with a family who were very invested, who were doing a lot of the monitoring. They were keeping track of things for their loved one, but they were keeping track of all the times they were going off the medicine or where there were problems. And so then the conversations were around where the mistakes or where the kind of going off the track happened. And so really just helping them to kind of reformat to identifying the strengths and the positive things happening, right? Like kind of use all that energy to kind of focus on the positive directional things really helped the relationship, the family system relationship, and also for the individual to internalize different messaging from their family. So those kinds of things. So again, not super detailed in a lot of areas. Happy to talk about more if anyone wants to talk about anything more specifically. But in summary, depression and psychosis is common. There are a number of factors that contribute to depression. Today, I focused on kind of thinking about just the response to the experience of psychosis as being a factor that contributes to depression, including the experience of marginalization and the related internalized stigma that can result from that, and some ways to maybe counter it. And just in general, negative social interactions and how to improve the social network, social interactions of individuals. And this includes, so the CBT approaches are pursuing the meaningful goals, facilitating in a sense an increased sense of control in relation to voices and symptoms, and then including family and support systems, so a more holistic approach when addressing that. Now I'll upload the slides to the iEqual format, so there's some additional resources that are connected in here and some references that go with it. So let me stop there.